We're here at the 50th anniversary meeting of the Society of Thoracic Surgeons to discuss an important topic for our membership, but more importantly, an important topic for our residents and our trainees and the surgeons that are really introducing into practice. This is a roundtable discussion on transition to practice. My name is Vinay Badhwar from the University of Pittsburgh, and I'd like to have our panelists introduce themselves, starting over here.
So I'm Vaporciyan. I'm at Houston, General Thoracic Surgery.
I'm David Odell. I'm a thoracic surgeon at University of Pittsburgh.
Mark Iannettoni, Iowa City.
John Ikonomidis, Charleston, South Carolina.
So each of these illustrious panelists have unique experience in resident education, program development, and leadership. And through this conversation, we'd like to hit a couple of objectives during this roundtable. First being defining what mentorship is and how we can prepare our graduating residents and surgeons earlier in their careers for a strong and stable introduction into the workforce. So I'd like to start maybe with Dr. Iannettoni. Mark, you've had a lot of leadership in Thoracic Surgical Directors Association and on the executive committee, and now in your role as vice. Can you just tell us what your thoughts are on mentorship, both in the residency status and then in the early transition to practice?
I think one of the concerns that the TSDA has as a whole is we hear a lot of times that our residents are coming out and they're maybe not as prepared as the expectation was for them in their initial job opportunities. And we know in general surgery that 80% of their trainees are now taking fellowships, and we really want to try to avoid that additional training for our residents as well. So one of the big concerns is setting what type of expectations does the trainee have when he comes out, and define that for them. But more importantly, one of the other considerations when we were looking at a transition to practice opportunity was what does the senior partner or the senior mentor, what expectations do they have? And sometimes these are mismatched, and I think it's important to try to define that for our residents and have some type of a plan and a paradigm that explains what they need to expect, what should be expected of them, and what uniform skill sets or opportunities we can provide for them.
That's excellent. David is currently the president of the Thoracic Surgical Residents Association. And David, what does it mean from a perspective of a post-general surgery fellow in terms of crafting their education, in terms of mentorship, and seeking the right training and development to launch them effectively into practice? What's the TSRA's position?
Well, I think, a couple of things. First of all, I'll address that true transition into practice first. I think for many of us, it's the first time that we've really gone through this process. Up until this point in our surgical training, everything has been very proscribed. It's been a series of very formalized interview processes and matches that have led us to places where it's been defined by other bodies that there will be good mentorship. There will be a pathway for us to continue to grow as surgeons. We now embark in a realm where it truly is completely up to the individual job seeker to figure those things out. And I think where we really struggle sometimes is having the skill set to critically evaluate the positions that you're looking at as your initial job, your entry to practice. And many times what's said and what's delivered are somewhat incongruent with each other. So I think that's one thing where some trainees are very fortunate to have excellent mentorship within their programs. Others are more left to their own devices. And I think to have some uniformity in that process, some uniform skill set that residents are able to leave with, not technical, not knowledge-based per se, but more practical as they evaluate a practice opportunity, as they evaluate a group of surgeons that they'll be joining, they evaluate the quality of that mentorship, I think is something that some people do very well, other people do less well. And it's an area where I think the people who run into trouble early on, really could benefit from some support.
Well, we should say also that David's made the transition already, and he's now an attending physician. So, our Vaporciyan has had a lot of leadership in Joint Council, the TSDA, and current chair of the Workforce and Thoracic Surgery Resident Issues. And as part of this transition to practice new task force that we're all a part of, we've discussed several ways to maybe take David's comments and turn it into some data, and maybe, could you tell us a little bit about the work we're doing?
So this is a gap in our trainees' education. We give them all the training they need to be good doctors, but then we don't take them to the next step to be good practicing physicians. And so I'm approaching this like a curriculum with this committee, and the first step in developing a new curriculum to teach is to do a needs assessment. And so that's been our first mission and our primary mission. We're going to collect data from the residents, from a discrete group of residents who have just entered practice through the gracious support of the American Board of Thoracic Surgery. We now have access to all the trainees who are coming to take their qualifying exam. So they will have been in practice for roughly about a year, maybe a little bit longer for some who are taking it for the second time. And we've crafted a survey to try and get the initial questions. As all surveys, we're probably going to generate more questions than answers, and I think it's going to take a few more iterations of this, working with various groups to get the right answers so we can build a curriculum that will address the problems that are present in our trainees.
So we're going to be having a pretty good survey, but easy to answer.
Absolutely.
That'll take a few minutes of their time during their stressful time of their exams, but it'll hopefully provide us very valuable insights into some details of the specifics of both training deficits or benefits, as well as early career introduction deficits or benefits.
Correct.
And that might help us as a society to help refocus our education, to provide them with the tools so that when they get launched into practice, they're well suited.
Yep.
So our residency education has also changed.
Correct.
And we no longer are solely dedicated to post-general surgery 2-year or 3-year fellowships. And now our residency is altered to accepting people right out of medical school in the so-called integrated program or I-6 program. John Ikonomidis from MUSC and has done a lot of work, particularly with Joint Council and TSDA on really formulating the I-6 education. John, can you just describe sort of what that is and what an I-6 or integrated resident is, and how perhaps this transition to practice can really help those people early in their development?
Sure, Vinay. The idea of the integrated program is to provide a comprehensive training experience for individuals that are interested in specialization in cardiothoracic surgery, with a real focus on the comprehensive nature and scope of training within cardiothoracic surgery. So there are core requirements for surgical management expertise that must be satisfied, but those requirements are packaged in a smaller time commitment. There's a considerable amount of freedom with regards to program directors in crafting a program where residents coming out of medical school get their core surgical training, but at the same time get exposure to cardiothoracic surgery earlier in their training, with the idea that they acquire a longer breadth of surgical expertise, but also a more comprehensive approach to cardiothoracic surgery through involvement with other rotations that they otherwise wouldn't get in a traditional program, such as imaging, cardiology, pulmonary medicine, things like that. And so the paradigm is intended to sort of decrease the breadth of training, but at the same time broaden the scope of it and provide and be attractive to students in the sense that the overall training time is shorter. I think it's important to step back a little bit and understand that the American Board of Thoracic Surgery is the final hurdle that all cardiothoracic residents must overcome. And the board believes that if you can overcome the hurdle of passing your written exam and your oral exam, that you should be capable of independent practice. And we are holding the I-6 residents to that same standard, and we are trying to configure our programs so that they will conform to that standard. It's very important. And so, although we're having a discussion today about transitions to practice, the expectation should be and must be that at the end of 6 years of training, anybody who graduates from any type of cardiothoracic surgical program in America and who can pass their boards should be capable of independent practice.
So a follow-up question to that is it truly I6, or is it's an integrated program through structure and broadening education, which I think is wonderful. In fact, our I6 program is some of our pride and joy of our education, the best and the brightest of medical students, and I think that's a wonderful future for our specialty. That I think the types of people interviewing and the interest level is high, and so I think our future is bright. Do you think that the I6 education will be limited to 6 years, or will it be more? Can you kind of give us your thoughts on that?
Well, I think the question you're getting at is how many of these residents are going to finish their training planning to seek a job right immediately. And there is some precedent in Canada where these I6 type tracks have been operational for some time. And in the cardiac surgical tract, virtually every resident who completes training will receive some sort of postgraduate fellowship. Now, we can talk about the reasons why that is, but I think that one of the overarching reasons is a desire to obtain subspecialty expertise in some area. And I think that it's reasonable to conjecture that there's going to be a fairly large proportion of residents in our integrated paradigms that will do the same thing. So the implications for us, I think, is we should probably look across our spectrum of programs and perhaps consider offering super fellowships or fellowships, or perhaps consider putting in place mechanisms for fellowship. For example, I don't offer a fellowship at the Medical University of South Carolina, but I think that some consideration should be made to perhaps doing that, and other programs should do the same, to offer a menu of fellowships, whether they be a fellowship just to get extra expertise in cardiac surgery or thoracic surgery in a different place, or whether it be to get expertise in a subspecialty such as heart failure ventricular assist, or valvular surgery, aortic surgery, or what have you. One of the aspects of transition to practice, and I think this is something that Ara was talking about, is that the results of this survey are going to be very important because they will direct the leadership within the TSDA towards perhaps having to satisfy a requirement such as this. Vinay, I'm interested in you maybe commenting a little bit about your efforts in this regard through the STS and sort of where you're going with your things.
Well, so within the SDS and the Workforce and Practice Management, one of our objectives and goals have been to prepare the early graduate or early surgeon member that has recently joined practice. So basically under the age of 45, that have been in the practice for 1 year, perhaps 3 years, that have had struggles, or maybe not have struggles, but provide some kind of access to information on contracting, on finding the right practice, so that we prepare them to enter into the workforce strong and secure. So we try to avoid the scenario where they enter into a practice and they realize, boy, this was not the right choice. And that's either because of market forces, that's either because of politics, mentorship, lack thereof, as Mark had very eloquently outlined the defining natures of that, and or contractual reasons that make them take their first step ineffectually. And as David said, that preparing and giving them information as to what that is, I think is still a lacking issue. We get calls to the STS all the time about, I'm in a bad situation, what do I do? And so, as John, you had outlined, we're all talking about having a formative education. So currently our formative education has been technique and knowledge-based on the principles and practices and goals of cardiothoracic surgery. Given what we've learned over the last really 2 years on some deficits that exist in our education on the managerial aspects, on the preparatory aspects of the financial, non-financial, strategic issues of practice, can you brainstorm a little bit and think, should we be altering our educational pathway to include small items like that? Maybe, Earl, you want to talk to
So,
that?
as I said before, it's a curriculum, and the first step in as a curriculum is to identify the needs that curriculum should address. So this survey is one step in identifying those needs. Once we understand what the needs are, then we can craft appropriate instructional methods to help our residents. Whether it becomes accepted as part of the full curriculum adopted by the board, which is charged with making sure they can practice the art of cardiothoracic surgery, or whether it would be additional courses available to trainees to satisfy specific individual needs of those trainees, is a matter for some debate. But I think developing the resources and making them available either through the STS platform or some other platform to the trainees is definitely the goal of this needs assessment and this attempt. But to do that without doing the due diligence up front and finding out where the gaps are would be a waste of resources and perhaps a waste of some people's time. Definitely think there is some role, and probably there's already a lot of instructional material already available through many of other workforces. Frank Nichols, working with the billing and compliance, clearly has some courses and some educational material available and ready, making that more front and center for our trainees earlier in their training as they approach matriculation is probably going to be a good thing.
And we'll have some more information available on the STS website exactly on those things. So in the small time we have left, you know, each of us are involved in our residency education, and I guess to follow up on your comments, instead of having formal, structured programmatic change, at least to our surgeon members that are involved in education and to our resident members involved in education, we need to seek out mentorship, seek out knowledge before you graduate on some of these things. Mark, what are your thoughts on that?
I think the easiest way for me to look at this is that these are very talented individuals, and it's no different than a college football player coming out and going into the pros. They may have all the skill sets, they may have all the raw talent and all of the ability to do what they need, but they still need the coaching. They still need the mentorship of the senior players. They still need the mentorship of the coaches. They need people to teach them about the financial aspects and things. So somebody has to be joined at their hip for the first couple of years, I think, until they're comfortable. I was very fortunate to have a great mentor, and I never had to worry about anything. Mark Oringer just took care of everything, and I just needed to work. And you learned from him how to do things. And I think that we need to take that mentorship seriously, because just throwing somebody into the water and hope that they can swim, yeah, some people will make it, but we really don't want to see these kids drown.
So mentorship, leadership, education, this is the residents are our future of our specialty, future of this society. So final comments, maybe go around the table on messages to our resident trainees and or resident recently graduated, first couple of years of practice as they transition. Final kind of take-home messages. Maybe start from Earl.
Mentorship is definitely the key, and I think one of the other keys is that one mentor is usually not enough. Each mentor will probably address different aspects. I have mentors who help me in my leadership role, mentors who help me in my training and residency role, mentors who help me in my clinical practice, and definitely mentors who help me in my financial role. So I think one of the take-home messages is you can't have enough mentors, and you should interact with them as often as possible.
David.
I think I would add two things. I think we've talked about this as a transition to practice, but I think one of the important concepts is that it's also a transition in education. Education hasn't ceased when you matriculate from residency. Your education continues throughout the entirety of your career, but especially importantly in those first few years of practice, and actively seeking out those educational resources, whether they be institutionally or at the societal level, or reaching back to the program from where you came. I would also add that I think it's important for the concept of bidirectional mentorship to be very well ingrained. Mentorship's a two-way street. It's important to have people who are invested in your career and can guide you and I wholeheartedly agree with the concept of multiple mentors being important for various aspects of one's professional career and development. But I think you also have to realize that the time to come to that mentor is not a time of crisis. The time to come to that mentor for advice and guidance is long before you get into that trouble. And I think, people oftentimes overlook that groundwork and only reach out for help when they truly desperately need it. And many times it's, not a situation where you can effectively help that individual.
Very good points. Mark.
I just think it's important to find somebody who cares more about you than the bottom line. And the one thing I would appreciate is if people remembered what it was like when you're 10 years out and be that mentor that you wanted to have.
John.
So I think that anybody who graduates from a residency program must be aware of their own limitations, and I think one of the goals of a good mentor is to work with an individual and help them identify those limitations with regards to their ultimate goals. If it's truly felt that it's appropriate that they go out and independent practice at that point, then that would be an appropriate avenue. If there are, if there's a requirement one way or the other for further training or fellowship, that should be recommended. And the final message I would say to residents is that your first job is your most important job, especially if you want to be an academic surgeon. It is a critically important decision that you're going to make in your career, and you must choose very carefully. And there are many, many factors, and this is where one or two very good mentors could probably be of most value to you in helping you select your job.
So we've heard wonderful concluding points on the plurality of mentorship, and that begins not just at your last 2 months of training, but it's formative all the way through your training process. And the reliability of your mentorship, and that it extends well into your transition. So finding your first job that actually has a mentorship access point, whether that be private practice or academic practice, it's of critical import that we make sure that that's established. And I think it's incumbent upon us as educators also to make sure that our residents are launched into that environment. For the surgeon members and educators, and even if you're in private practice, these are the future of our specialty, and we need to really concentrate on helping them in that transition. And for the residents and candidate members of the STS, seek that out early, whether you're an integrated resident or whether you're a graduate resident doing a fellowship, seek it out even in your first year. And so you structure that mentorship pathway. So it's been an excellent commentary and discussion. And with that, we'd like to close our roundtable discussion. And obviously, you can always access the Society of Thoracic Surgeons for more information through the website and through the STS proper. So with that, I thank you all for your attention on this 50th anniversary discussion on transitions to practice.